will be joining us here shortly. So I'm pleased to introduce Dr. Pramod Pillai. He is the associate professor here with the neurosurgery department. He's the director of endovascular and cerebral vascular neurosurgery here. He had extensive training in India, full training all the way to board certification level in India before he came to the US, and then did a full track of training here in the United States as well, and then joined our faculty in 2015. He's a wonderful colleague to work with, very knowledgeable, just an exciting topic for him to present. As he already mentioned, between us, it's a very broad topic at the same time, but the topic of aneurysmal subarachnoid hemorrhage, there's just so many aspects to it that are intriguing, and I'm sure we're going to learn a lot today. So welcome, Dr. Pillai, and you can take over. Thank you.
Thank you. Thanks for the kind introduction. Yeah, let me share my slide. Yeah, I was thinking, I mean, it's a very vast topic. We can try to, discuss as much we can in this 1 hour. I don't have any disclosures. Let me see if I can you see my slides?
Yes.
Okay.
Yes.
Okay. So I just wanted to, briefly talk about our institutional guideline in aneurysmal subarachnoid hemorrhage, and also we have one of the recent American Heart Association guideline, which we could discuss those some of the aspects of management of aneurysmal subarachnoid hemorrhage. So incidence of subarachnoid hemorrhage, reviews are varying from 2 to 16 worldwide. Finland, Japan, some of the Asian countries has higher, incidence of subarachnoid hemorrhage. In US, it's about 9.7 per 100,000. But again, we have trouble, capturing all the subarachnoid hemorrhage because estimated incidence of, about 12 to 15% of patients they don't make to the hospital admission, and they at the scene. So we this number probably not accurate. I want to talk about a couple of aspects of the epidemiology. The age, we know that it is it's a middle-age presentation, typically above 50 years of age, and higher incidence of women compared to the male, which is being seen in that's a common trend. And other things about the racial variation, which is again, it's kind of impressive and important. Black, the African American population and the Hispanic population has a higher incidence of subarachnoid hemorrhage, and also we find that the outcomes and actually as poor outcomes in this population as well. So that's what those are the few aspects of the epidemiology. So this is an important discussion when it comes to what are the risk factors of patients having an aneurysmal subarachnoid. This is actually particularly important when it comes to a patient comes to a clinic with an unruptured aneurysm. We want to see what are the risk factors which could lead to subarachnoid hemorrhage, and there's any particular factors we need to be looked up and wanted to be, we can select those patients to treat it before they get into have a situation where they have a subarachnoid hemorrhage. This is particularly important, like uncontrolled hypertension, chronic smoking, alcohol abuse, and particularly the use of sympathomimetic drugs, which is kind of a problem in our population. Female sex, again, it's consistently shows increase in of subarachnoid hemorrhage. It's a kind of risk factor when it comes to when you select patients for treatment, especially in a situation of unruptured or incidental finding of aneurysms. Prior history of subarachnoid hemorrhage, it's a very important factor for patients to have an subarachnoid hemorrhage. Family history of aneurysm, again, if you have 2 family members, immediate family members having a positive history of subarachnoid hemorrhage, and aneurysm has increased risk of subarachnoid hemorrhage in that patient. Particularly, it's important that there are two situations where you have, familial or higher incidence of both multiple aneurysms as well as bleed. One is adult autosomal dominant polycystic kidney disease. Another one is type 4 Ehlers-Danlos. Again, if you have any questions in between, you can always interrupt me. You can, this could be an interactive discussion. But again, when we talk about aneurysms, classically we'll say the patients with larger aneurysms are more likely to bleed. But we see that often. I mean, in this particular case, if you see this patient came with a poor grade subarachnoid hemorrhage, and if you see in the angiogram, it's a very, very tiny aneurysm. It's less than 2 millimeter with a poor grade subarachnoid hemorrhage. She actually came in cardiac arrest. She was in cardiac arrest before came to the hospital, and she had a very prolonged recovery time. This is another patient. Again, she was in 40s, high functioning. She came with, she has no risk factors. She's not a smoker. She has no hypertension, no other risk factors. She came with this 3 millimeter anterior communicating aneurysm with rupture. So again, this is one case we can say, this is a giant aneurysm. She has an aneurysm size of a 4 centimeter. She actually came with no bleed, but with the mass effect. So it's really difficult to say, what aneurysm is more likely to bleed. I mean, we have a general guideline, but it doesn't really respect, when it comes to rupture in aneurysm cases. So we have to be really careful selecting patients especially when it comes to a situation where the patient was found to have an incidental finding of an aneurysm. So this is one patient, an unfortunate patient. She's in 70s. She recently came to our ER with sudden onset headache. So she was evaluated by the ER physician, got a CT scan, found the subarachnoid hemorrhage. She was called, and the neurosurgeon was called in. While the resident was walking into the ER, she went to the bathroom. On the way, she collapsed. This was within maybe an hour or two from the admission. She had a massive bleeding, and we took her to an angiogram. And you see, this is a lesion we see. I mean, it's a very tiny lesion. It's again about 2 millimeter ruptured, which is re-ruptured within a few hours of admission. I mean, again, it's really difficult to predict what patient is going to have bleed and what patient is going to have a rebleed. Right? I mean, this is a problem we often encounter in this population. And that there is a lot of discussions and research about inflammatory mediators of aneurysm formation and rupture. But again, we don't have a very robust data to say that that's one of the way to predict aneurysm growth or rupture. But again, there are a lot of research ongoing, which is actually addressing this role of inflammation in aneurysm. This continues to have, in spite of all the advancement in our treatment, both in critical care and interventional treatment, still the mortality and morbidity is high. If you look at the trend of fatality rate, I mean, if in mid-70s it was around 57, we still have a fatality somewhere around 36%. So we are not made significant improvement in spite of the best treatment we have at this point. So there is significant burden on the medical expense here. So when it comes to workup, I will briefly go through it. It's I don't want to we all know what's the typical workup in subarachnoid hemorrhage. The most important thing is the clinical suspicion. This is one thing we often emphasize. Even today, if you look at the studies, I mean, we almost like 15% of the patients are missed at the first time of admission in the ER. I mean, so that's a very important thing. I mean, it's often the clinical suspicion is the most important aspect, diagnosing or working up of subarachnoid hemorrhage. Actually, there is one study, one algorithm, which is actually proposed by a Canadian group, which is kind of gives an idea of how you can kind of screen patients in the ER. So if any of those features in the patients, like patient is over 40, if the patient has neck pain or stiffness, if there is a witness loss of consciousness, or there is an onset which is close to an exertion, thunderclap headache, patient has neck mobility issues, any of those 6 factors, if you see those in the patient, the headache in the ER, be careful, make sure that you have a workup in line with subarachnoid hemorrhage. Again, this grading system, we've used it often. Most of us are aware of this. Hunt and Hess is the most popular one. It's not the best. WFNS is more objective, but unfortunately, it's not not used popularly. And Hunt and Hess is the most commonly used grading, which is again actually gives an idea about grading in relation to the functional or clinical outcome. Hunt and Hess also, it can modify based on the associated systemic disease. Like for example, if the patient has a grade of 2 with a systemic disease, either diabetes or heart disease, then the grade goes to one level above, so it becomes 3. But again, WFNS grade is the most objective way of documenting the grade, clinical grade. We also have a CT grading, which is again, there is some controversy about the grading. The Fisher grade was official grade, which was the original grade, which was based on the original imaging studies, but now we modified with a modified Fisher grade. It has 4 grades. So it is a combination of subarachnoid hemorrhage with or without IVH. Right? You can have a minimal subarachnoid hemorrhage with IVH, no IVH, or you can have a diffuse or focal thick subarachnoid hemorrhage with or without IVH. Again, this grading was mostly to kind of predict the incidence of spasm, like delayed ischemic events. Again, there is some limitation with this grading, but overall it gives some ideas. At least in the first 2 to 3 grades has gives some kind of graded incidence of spasm post bleed. You guys have any questions at this point? I mean, I'm open to any questions in between if you have. Workup, still the most important workup at this point is the non-enhanced CT scan. And especially the new generation CT scans are very good picking up with a high sensitivity and specificity of subarachnoid hemorrhage. So often we don't miss on a non-enhanced CT scan. But if you still have a high degree of suspicion with subarachnoid hemorrhage, LPCSF is still the way to go. But there are certain centers actually started working on MRI brain, which has sequences like SWI, which has very sensitive way of picking up even delayed or the past subarachnoid hemorrhage. But if your CT is negative and the MRI is negative, still if you have a doubt, you should go ahead with the LPCSF rather than sending the patient home. DSA is still the gold standard. Once you have a diagnosis of subarachnoid hemorrhage, then that should be the next workup. So that's the kind of workup we do in the ER. Once we know the patient has subarachnoid hemorrhage, and obviously we do the CT angiogram, that will be the next non-invasive way of looking at the vascular anatomy. And often we see the lesions on the angiogram. I mean, obviously the lesion is too small. It's less than 2 millimeters. Distal vessels, sometimes you may not be able to see it. So those cases with established subarachnoid hemorrhage, obviously the next step will be a diagnostic circular angiogram, which should include at least 4 vessels of the brain. So what's the next step? I mean, at this point, our idea of treatment is we want to treat the aneurysm which ruptured, but we also want to make sure that the blood pressure has to be stabilized, has to be controlled in a way that we should not cause stroke. We should not have a severe hypertension. At the same time, we don't want the uncontrolled hypertension to cause a rebleeding. So obviously we want to maintain the CPP. So it is a tight line where you want to have the normal CPP. We don't want the hypertension which causing a rebleed. At the same time, we don't want and control or unexpected hypertension, which could be risky for the patients with stroke. So at that, here we always talk about what's the optimal blood pressure, right? There is no real consensus on this blood pressure management because the most recent AHA guideline is kind of gives an idea about giving 160, but there is also discussion about lowering the blood pressure for a younger patient. If the pre-morbid blood pressure is normal with a normal ICP, you could keep the blood pressure on the lower side. Whereas if the patient is in the middle age, over 50, with the pre-existing hypertension, or patient with high ICP, it's reasonable to keep the blood pressure on a higher side. But the idea is you don't want to have a low CPP at the same time. You don't want to have the patient have a risk of rebleed. So that's the concept of blood pressure control. And it's a very important aspect in the management of subarachnoid hemorrhage. In fact, we have a subarachnoid hemorrhage activation protocol guideline in our institute, which actually is unique compared to the many centers in the country, where we have activation which goes to the stroke team, the neurosurgery team, as well as the critical care team. So the idea is to have this patient stabilize as quickly as possible so that we can avoid that kind of, the changes in the blood pressure while patient is getting worked up in the ER, and then having a rapid transfer to the ICU, so we can start treating the ICP and the blood pressure and then plan for further treatment. Role of antifibrinolytic. This is kind of a way, it had a lot of interest in the past. Is there any role in this current practice? We don't do that often. In very, very rare situation, Loma Linda, we had, patient who had to have this antifibrinolytic treatment. The idea is to, keep the clot around the aneurysm so that we can try to prevent a second bleed, especially if you have a unavoidable delay in treating aneurysm. The patient is, very hemodynamically unstable, or there is several systemic issues going on, or there is issues, getting this patient to a treatment. That's the only situation we try to do this treatment, and it's a short term within less than 72 hours. There is, again, we have to be concerned. There is an increased risk of spasm on those patients who get this treatment, but obviously, this is not something we do often. Then once we stabilize, so once we have the medical treatment to optimize the patient, at the same time, obviously, those patients often get treatment for the ICP. And again, it depends on the situation. If the patient has a prominent ventriculomegaly, there is a lot of brain swelling, with an altered mental status, often those patients get EVDs. The external ventricular drain, again, there are certain things we need to be careful. One, the placement of the EVD. We have to plan the EVD placement based on the approach we want to do. Like if the patient has to have a right side of treatment, we wanted to have the EVD on the left side, right? Because we don't want to take this patient for the surgery on the same side we have the EVD. Typically, common practice is to do a non-dominant side EVD, but sometimes, as I said, in cases we have to go with the right side approach, we want to have the EVD on the left. Again, institutionally there are variations. Some of the centers they're very conservative on placing an EVD because of the concept of an intra-procedural rupture is much higher. Even though the chance of or the incidence we encounter is very, very small, but at least the theoretical possibility of a rupture is higher if you, rapidly decompress the ventricle. And again, we have to be controlled when you do the drainage of the CSF. At the same time, if the patient is wide awake with a ruptured aneurysm, we don't want to put we don't have to subject this patient with a painful procedure. So we have to be careful about that situation. So often in those situations, we try to plan the procedure along with the anesthesia procedures, which will be either an endovascular treatment or microsurgical treatment. So when it comes to what's the best way to treat this, and that's the next thing we have to see, right? We want to see what's the best way to prevent rebleeding in this patient. So this is a place we have to have a comprehensive multidisciplinary discussion, which has to be including a cerebrovascular surgeon, should be an endovascular specialist, as well as a critical specialist, because all three has to make the decision what will be the best treatment. Because we had situations, when you look at the aneurysm, maybe that's the best way to treat with surgery. But then we talk to the critical care, we know that the patient is too unstable for an open surgery. And this is probably the best way to treat with endovascular options. So sometimes we have to tailor our treatment based on patient situation. Just not looking at the pictures, we probably won't be able to make the decision. So that's why it's important to have that kind of combined interaction between open surgeon as endovascular specialist as well as the critical care. So we, again, there's this ongoing discussion about what's the best treatment, right? So the best study we have is which is one of the most popular study we have, neurosurgery, is an ISAT, which actually has looked at a group of patients which were both suitable for endovascular and surgical clipping. And then they randomized those patients to two groups and then looked at what was the outcome on those patients. And we found that endovascular patients' functional outcome was better than surgical patients. But again, remember, this was a subgroup, not the whole group. It was a subgroup of patients who were amenable for both options. And we found that endovascular option was better. And in fact, we looked at long-term follow-up. We found the same thing. I mean, in fact, some of the surgical group had made that improvement in the long term, but still endovascular group had a better outcome. So what does that mean? So that means if you have a patient who has a subarachnoid hemorrhage with an aneurysm, and we find that the aneurysm it can be treated both ways, we should prefer endovascular treatment. But also you have to remind yourself about a couple of things in this situation. Endovascular options has a better outcome, which is consistently shown. At the same time, the recurrence is much higher in endovascular treatment. And so this rebleed. So you have to be really careful treating those patients, especially if the patient has to have a regular, ongoing surveillance on this patient. If the patient cannot come back for regular follow-up, then endovascular treatment probably is not the best treatment in the situations. But again, that's something you have to be aware of that, because endovascular treatment is, even though it has a better outcome, it has some limitations. Generally, when again, we have to look at every case on a case by case. But generally, if you have a patient who has uncontrolled intracranial hypertension, large hematoma, or if the patient has a middle cerebral artery aneurysm, which is usually not amenable for endovascular treatment, or sometimes then a complex ACOM aneurysm, which is not amenable for endovascular treatment. Those cases, we typically go for surgical treatment, provided patient is medically fit. Whereas if the patient is, suppose patient is over 70 years, if you have a poor grade subarachnoid, particularly lesions like basilar apex, we typically don't want the patient to go to surgery because they are, their outcomes are poor. So again, this is just a general guideline. It doesn't mean that we have to, respect this, guideline. But again, this is a place. I think one message I want you to bring to the rest of the team is that the multi-speciality or disciplinary discussion about the patient management is very, very important, especially in a situation like this. So I want to talk about a couple of patients. This is one patient actually. I don't know if you can see this is a aneurysm which is coming off the MCA. You can see it's a wide neck. Yeah, the branches are coming off the base of the neck. It's no way we can do a coiling treatment in this case. She was in the 80s, older patient, subarachnoid hemorrhage. Unfortunately, she's not a good candidate for surgical treatment, endovascular treatment. In fact, somebody actually tried to endovascularly coil it. It doesn't work. The patient came to us. We have to do the clipping. Similarly, this is another patient. She's in 50s. She has a bilateral MCA aneurysm. One was ruptured. This was obviously the one was ruptured. So she, again, the aneurysm morphology, the age, good grade, good candidate for surgery. She underwent surgery. So she actually had surgery for the ruptured part first time, and then we brought her back for the second part of the surgery. So this is what the clipping we talk about. It's the next extravascular approach. Basically, we are obliterating the aneurysm with a clip on the aneurysm neck. I want to show another case, which is similar situation, younger patient, small aneurysm, which could have been both endovascular and surgical. Both options were good for her, but we decided because we know that endovascular treatment has a better outcome, so we went ahead and did the treatment with the coiling. But this is what I was telling you. The same patient came back for, she's high functioning, she works in real estate. She came back for 6-month follow-up, the aneurysm was no aneurysm, but 1-year follow-up, this was aneurysm, the follow-up angiogram. You can see that clearly the aneurysm is grown, obviously has to be treated. So this is a problem with coiling treatment, right? We have to be careful following these patients closely so that we don't miss this kind of recurrences. So again, because of the fact that endovascular option has a better outcome, we wanted to expand the envelope to see if we can do treatments endovascularly, otherwise treated by open surgery. I mean, that's a place we have controversies, right? In situations, I mean, we could use a stent in a ruptured aneurysm to treat. If the patient has no way to go to a surgery, we could do that. The problem is that that's not with, it has some, problem with that, right? So when the patient gets the stent, we have to put those patients on antiplatelets. Obviously, this patient had a bleed, and often this patient has ventricular drains and things like that. Patient need to go for multiple surgical procedures. So not a good ideal situation, but situations are there. Sometimes you may have to do that, if you have no other options left behind. So we may have to do that options. But again, this is something, coming in, and few centers started doing that, especially with the newer stents, which has less thrombogenic activities compared to the older stents, which could be an option in certain situations. Like there is another device which has been used recently. Again, this is not a stent. This is an intrasaccular device, which actually perfect for a wide base neck, wide neck aneurysm. For example, in this case, you can see the aneurysm has a wide neck. It's a basilar tip. There's no way we could have done a primary coiling in this case. Again, if you have to do a coiling, you have to put a stent. Obviously, stent will have antiplatelets and other things. So the best thing was to either treat with surgery, or this is the new device. This actually was the first device in Inland Empire we used in a patient with this kind of situation. So, and it worked well. I mean, this is the follow-up, and patient did not have to have any surgery, and there was no need for any antiplatelet treatment, and patient did well. So this is a possibility too. Sometimes, I mean, again, this is one case I want to show, situations we don't have much option. Like in this case, this is a young lady. She came with subarachnoid hemorrhage. You can obviously see there's a PCOM aneurysm, which is a very, complex shape. We ended up coiling it. Unfortunately, day 7, she started having vasospasm. So this is the initial angiogram, and you can see the angiogram shows severe stenosis of the MCA and ICA, and she also became very symptomatic. Unfortunately, she also had what we call a situation called cardiomyopathy, like neurogenic cardiomyopathy. Her ejection fraction dropped to 15. So this was a situation. Generally, situation like this, we try to treat them with, angiogram, with spasmolytic. But the problem with spasmolytic, we have to do multiple procedures. And because that means the patient has to come to the angio room on a daily basis. That will be multiple sessions. And this patient already having pulmonary edema, she has cardiomyopathy, and she's on a vent. She cannot be transported multiple times. So we decided that, okay, the best thing is with a more durable treatment in this situation like this will be a balloon angioplasty. And that's what we did. We did an angioplasty. Unfortunately, what happens with the angioplasty, because the blood vessels were not, this is a ruptured case, she actually developed a pseudoaneurysm right at the place we did the angioplasty. Then what to do? So patient has spasm, which is obviously she's symptomatic. She's having cardiomyopathy. She has pulmonary edema. On top of that, she has this aneurysm, which is actually caused by our treatment. So this is a very difficult situation. In olden times, what we do in this case is that either we have to sacrifice the lesion and then do a bypass. Otherwise, it will be extremely difficult to preserve that vessel because primary coiling of a pseudoaneurysm is not going to be durable. So here, we actually tried to use the newer device, which is not typically done in other cases. We used a pipeline. It's a flow diverting stent. The stent we see here is a conventional stent, whereas this is a flow diverting stent. You can see this, the braids are much tighter. So what it does, it tried to preserve the flow through the stent so that the aneurysm doesn't get the blood flow. So the blood vessel heal over time. Again, this takes time. We know that it's a pseudoaneurysm, it's ruptured. We know the patient has subarachnoid hemorrhage, and it probably won't heal immediately. So it is a complex situation. And in fact, that was the only way to preserve her vessel. So we ended up doing that, especially with all the other things she was going through. Actually, she did well. Actually, we did a follow-up angiogram at 6 months. The aneurysm is completely healed. And in fact, she also improved to pretty much normal. But again, this is not a common situation we want to do. Again, this patient has to be on dual antiplatelet for first 3 months, and she was on antiplatelet during the hospital stay. So it could be a little bit complex with that situation. I also want to talk about a little bit about two aspects in subarachnoid hemorrhage. One of the discussions in subarachnoid hemorrhage, there are two issues we talk about. One is early phase brain injury or early brain injury, which usually happens within the 72 hours of the bleed. And then you have delayed cerebral ischemia, which is otherwise called DIC, which happens with after 72 hours. So the two pathophysiologies are extremely different. Early brain damage happens within that 72 hours. Often it's difficult to do anything at that point because the patient is not even in the hospital. Sometimes the patient is not even in the hospital, right? And it could be coming from the microcirculatory constriction. It could be probably from the apoptosis. You could have the blood-brain disruption. It could be ICP issue, the brain edema. All those things can cause the early brain damage. And actually, in fact, there is a lot of research is going on how we can modulate that early brain damage so that we can improve the outcome. And then obviously the delayed cerebral ischemia, which is often documented after 72 hours, up to 14 days, even up to 21 days. So generally, the definition of the delayed ischemia is like if you have new deficits, or if there is a decrease in the GCS score, at least 2 points below the baseline, and it has to be, the symptom has to be lasting more than an hour, and there should not be any other causes like fever, infection, ICP issues, or epilepsy, or any of those things. And obviously, it should not be after a treatment. It should not happen after. That should not be after the treatment. So there are two concepts in the brain injury: the early phase and the delayed phase. Obviously, we also need to talk about the sympathetic activity, which we talk, which is again from the acute catecholamic surge, which can cause two problems. One is the myocardial injury, which obviously can cause the cardiomyopathies and valve dysfunction, and then obviously the pulmonary dysfunction. Both can be a problem for outcome in these patients. One of the ways, one of the easy way to look at this, by serum markers, lactate level. So that's something we should be looking at, especially looking at catecholamic disturbance and which is leading to myocardial and pulmonary dysfunction. In our institution protocol, we typically do echocardiogram at the admission, which will kind of gives in a baseline so that we have we could potentially follow those patients closely. And obviously, this will be also useful in terms when the patient goes into delayed ischemic events, where we have to be careful about the fluid status. Obviously, pulmonary dysfunction is another thing we have to be careful about as well. So the delayed cerebral ischemia, I just want to talk about a few things. Again, this is usually between 4 and 14 days. the two things we need to be aware. One, we often get confused with cerebral vasospasm to DCI. It's not the same. If you look at the incidence of spasm to the DCI, clinical radiological spasm happens about 50% of the patients. That doesn't mean that all patients has to have the DCI, whereas there are several other factors could be causing, delayed cerebral ischemia. Whereas if you look at this chart, we can see the things which can cause delayed ischemia, not just the spasm alone. It could be vascular dysregulation. You have microthrombosis. Could be cortical spreading depolarization, which is kind of a research topic now, and also neuroinflammation, which we don't really talk much about it, but it's again in neurovascular research field. This is something very interesting in terms of how to modulate those ischemic events. So we talk about DCI. The pathophysiology of DCI in subarachnoid hemorrhage, not all DCI is related to spasm. There could be other reasons which could be leading to this. And then when it comes to spasm, we all know about nimodipine. We routinely use nimodipine in subarachnoid hemorrhage. Why we use it? It's very important to know that nimodipine does not improve spasm. The only finding we found in the studies with nimodipine is that nimodipine improves the functional outcome of patients with subarachnoid hemorrhage. So that's the only thing we know. Whether that is the relation to the calcium metabolism, or is it related to spasm? We don't know. There is no relation with spasm and nimodipine. So that's something you need to be aware of that. But we still use nimodipine as a treatment option for all patients with subarachnoid hemorrhage, at least for 14 days. So then what are the other ways to treat cerebral vasospasm? But conventionally, we talk about Triple H, right? Triple H is three things: hypertension, hypovolemia, and hemodilution. But in practice, and especially in our guideline, we don't typically do that three. We look for more for hyper hemoaccumulation, which is basically to improve the blood pressure. We also try to keep the volume stable. We don't want to have too much volume. We don't want to be hypovolemic. We want to keep more of a euvolemic state. And also, we want to try to avoid anemia. We don't want to be, specifically looking for hemodilution, which is been classically described, but we don't do that in our practice. Again, the role of transcranial Doppler. This is one of the modalities we do routinely in our cases. It's actually a very, bedside, very useful, tool. It can be done at bedside. So it is easy to do on a daily basis. But there are certain issues. I mean, it is dependent on the technologist who does it. I mean, it has to be very careful with selecting the windows. And also we need to make sure that we have the right parameters we're looking at. Typically what in our institute, what we do is we do a baseline TCD at the time of admission, and then we follow along. The numbers, we look at two things. One, we look at the mean flow velocity, which is, anything above 120 has, is pointing towards spasm, but we also look at the Lincard ratio, which is basically looking at the ratio between the MCA velocity versus ICA velocity. Basically, this is to try to avoid the situation where you have a hyper hemodynamic, like hyper circulatory state, where you have increased flow through the ICA that can also contribute to the increased velocity in the MCA. So I just want to rule out, exclude that situation. At that, again, we also use perfusion images. Some of you may know about this. We typically try to do an MR perfusion. The MR perfusion, what we're trying to do is basically looking at the cerebral blood volume, cerebral flow, as well as MTT. MTT is the most important parameters we look at. For example, in this case, this is one of the patients we had in the previous slide. You can see this left MCA territory delayed MTT, which is kind of shows the hyperperfusion in this region. Obviously, MRI also will give an idea about how much actual stroke we have, because if you have a large stroke, obviously we are not going to be able to treat them because of the risk of hyperperfusion injuries. Again, MR perfusion is a really good tool, and some centers use CT perfusion as well. Again, we combine different aspects. We look at the clinical picture of the patient, we look at the TCD, we look at the angiography pictures, either an MR angiogram or a CTA. And then obviously, we look at the perfusion. I mean, all those pictures together, we will make a decision whether this patient needs either continued medical treatment versus further treatment. Again, if you look at the literature or even the guidelines, we don't have a real clear-cut understanding about what patient need to go for endovascular treatment and what patient has to be treated medically. It's really a vague area, which again, it's depends on each center. I know centers which doesn't believe in endovascular treatment because they don't have endovascular option. Because again, it depends on early different situation. The endovascular treatment, what we do, there are two ways we treat it. One is drug administration intraarterially, and the second thing is the angioplasties. Again, each one has advantage. If you are talking about complication risk, it's much lower in intravascular administration of medication. The problem is that it doesn't last long. So usually it doesn't last more than 12 to 24 hours. So you have to bring this patient back for treatments. I mean, every angio procedure has, if you accumulate all the risk with each procedure, obviously that risk also goes up. But whereas angioplasty, especially with balloon angioplasty, it has a long-lasting effect. But obviously, it may involve anesthesia. It may involve more invasive procedures. Obviously, the risk is a little bit higher, especially when the patient with a ruptured aneurysm. So we have to be careful what's the best treatment for this patient. We talked about a triple H therapy. That's kind of an obsolete. We don't do that anymore. So we usually go with, mostly euvolemic and hypertension. So this is one case I want to talk about. So we recently had a patient. She had a PCOM aneurysm, which was coiled. She came in grade 2. Like day 7, she started having clinical vasospasm. Obviously, the angiography picture also showed the spasm. Her TCD is also gone up significantly on the left MCA. And we did the MRI. That was MRI shown before. The MRI perfusion showed focal perfusion deficit on the MCA. This is a patient, could be a good candidate for endovascular treatment. And that's what we did. And this is a treatment, again, with the balloon angioplasty, and this is the final result. So, I mean, again, you have to be, you have to look at various aspects not just by the TCD or just not by clinical changes. You will not be able to make the decision about what treatment to be done. Fever management, again, I know I should not be the person who will be talking about it. This is mostly a critical care aspect. We know that temperature, poor, the fever has a bad outcome in patients with subarachnoid hemorrhage. It's the same with any critically ill patients. We also see that patients clinically poor grade admission, the grade subarachnoid hemorrhage at admission or intraventricular bleed patients also has high incidence of fever. So obviously we have to be vigilant about this situation. And also obviously, any other causes of fever in these patients, especially in a critically ill patients, like pneumonia or DVT or UTI, those things also can cause fever. Obviously, we have to treat fever as any other critically ill patient. Coming to blood sugar, same, I think we could, relate to this one to a traumatic brain injury patient or a critically ill ICU patient. We usually we don't want to be too aggressive with glycemic control. Stroke or European Stroke Organization is a guideline which actually says about 180. That's a top level, and they say. And also, if you look at the lower limit, it's about 90 milligram per deciliter. So if you want to say between 90 to 180 is probably a reasonable way to go for. But again, there is discussion about what's that outcome with pre-existing glucose intolerance. We don't really have much data on it, but again, there is some trend that pre-existing impaired glucose tolerance has bad outcome on patients. So again, this is not very clear. Second thing is that is any difference when you're looking at early brain damage versus delayed brain damage? Is any change in glycemic management? Again, I didn't see any literature looking at aspects clearly. So if you have opinion, if you have it, we can discuss it. But as of now, we don't have it. So far, we talk about glycemic control, which is not tight, between maybe 90 to 180. Hyponatremia, very important aspect in subarachnoid hemorrhage. We kind of go over it very consistently on patients with subarachnoid hemorrhage. We typically say less than 135 is kind of a cutoff. But again, you have to be thinking about multi-factor cause. We always talk about cerebral salt wasting, but it could be, steroid deficiency, it could be SIADH, it could be hypovolemia. So it's very important to look for those causes before we treat it. Again, optimal threshold, we are a little bit more aggressive in our institute. We keep it around 140 to 145, but most of the guidelines, especially AHA guidelines, say about 145. So, I mean, if you can keep it above 140, it's reasonable. We also find that, this delayed cerebral injury patients do poorly if you have hyponatremia. So it's very important to treat them to have it, with the optimal level. But again, we wanted to try to avoid hyponatremia as well. Again, this is something talk in the guidelines, how many days you should keep this patient in the ICU. But again, if you look at our patient population all over the place, we will have patients sitting in the ICU for months, maybe 3 weeks, 4 weeks, whereas some of the patients get out of the ICU earlier. It all depends on the grade of the patient, the post-op complications, the need for ventilative support, need for EVDs and other surgical procedures. So it depends. But on average, we say about 12 days. I mean, this is something we talk to the family too, because we have to be educating them about, this just fact that we treated the aneurysm doesn't mean that patient will be out of the ICU soon. Again, I can talk, I don't know how much time we have. Maybe I can just talk a little bit about anesthesia issues about aneurysm. Again, general anesthesia versus conscious sedation is a hot topic. It's particularly in stroke treatment, but in some centers actually looking at treating with aneurysm treatment. So, but generally, in our institute, the patient with ruptured aneurysm, we try to treat the patient with general anesthesia. The problem with anesthesia, obviously, is intraoperative hemodynamic instability. That's a big thing. I mean, this is particularly important in stroke patients too. So if it is properly administered anesthesia with the tight control of the blood pressure, it's actually better from a treatment standpoint or interventional standpoint. But whereas if you have a possibility of hypertension, especially in a situation with brain injury, it's not a good thing for the patient. Again, one of the aspects anesthesia consideration is intraoperative rupture. Again, it is different, both endovascular and open. Open rupture is more obvious. We have better control, whereas intraoperative rupture in a coiling case, we don't have much of a control because it's inside and we are working endovascularies, right? So, and also we have to often use heparin or anticoagulation during endovascular treatment, which will obviously make the things worse. One of the things we talk about is, patient being completely sedated while we're doing the procedure. And then often those intraoperative ruptures often comes with a sudden surge in the blood pressure, which is kind of gives an idea that there could be something happened with the rupture. So again, when it happens with the intra procedure, whether it's surgery or endovascular, the treatment management will be slightly different. Another aspect in anesthesia will be the temporary clip time. Again, this is only for microsurgical treatment. Obviously, when we do a temporary clip, the circulation has been arrested. So there is a risk of hypoperfusion to that region of the brain. So we wanted to make sure that the patient does not have any hypertension during that time. In fact, we want to keep the map at least 20 millimeters above the baseline, so that we don't get at least we can keep the collaterals intact, so the patient should not get an active stroke. Again, induced hypothermia. This is one of the hot topics in critical ill patients, particularly in traumatic brain injury. Also, people have actually looked at hypothermia. Some of the studies actually showed better outcome with hypothermia, but obviously it has to be controlled. And obviously there are complications from hypothermia, particularly the infection risk. Seizures, again, we do anticonvulsant treatment, prophylactic. It has to be tailored to the short term. We usually give it for a week or 10 days, and then we stop it. Routine long-term use of anticonvulsant is not recommended. We don't typically do that. So when you look at the outcome, a lot of discussion on this aspect. How do you can improve the outcome? I mean, are we stagnant on the outcome? So there's one of the things we talk about is that two things. One, having multidisciplinary approach to the treatment. That's very, very important in this case, because often what happens is, in centers where they have one particular treatment option, they tend to treat every patient with one treatment. Whereas when you have centers like us, where we have people with different expertise and specialization, and we have options for different treatment. We don't have to just focus on one treatment. Another thing is that high volumes. Fortunately, our stroke team can address that. Some reason our population has a higher numbers of subarachnoid hemorrhage and higher number of brain bleed, which we have better experience with this patient population. So I think that's actually also very important in terms of outcome. So in fact, actually people talk about transferring patients. If you have, if your subarachnoid hemorrhage volume is less than 10 per case, 10 cases per year, it's safer if we can transfer those patients to higher volume centers. So that actually, in fact, gives better outcome for the patients. Again, other things about outcome, we have to look at monitoring of the complications, both surgical and interventional procedures. And also we should look at the long-term functional outcome, which is, again, it is kind of neglected, because we always talk about immediate outcomes, 1 month, 2 months, patient may be okay. And also look at what is the outcome you're looking at. Are we looking at the psychological or cognitive assessment, or are we just looking at just regular neurological outcome? And also we need to have a support system. These patients have a lot of long-term issues. We need to continue to follow them. We have a support group in our institute. We monthly meet with them, and we talk to them about different issues that they encounter. Again, I had to just highlight in the issue, the concept of multidisciplinary approach. We don't want to, I like this picture, the fact that, people, this is a natural way of addressing things. And if you have something, and if you feel like everything is a nail and you only have hammer, that's what's going to happen. So it's better to have the better, different options, so we can come with better treatment. I think that's all I have. Any questions?
Thank you, Dr. Pillai. That was a wonderful review of a complex topic. While others are thinking of questions they might have, can you just mention why, because I work, as you know, on SICU as well, why, and is it settled science that traumatic SAH does not have DCI or vasospasm even in high volume?
Yeah, there is, there was some discussion in some of the neurosurgery conference about this traumatic brain injury. Actually, some of the studies actually came from the military neurosurgical study, like people in, particularly there was a study from Iraq where they looked at the spasm incident. Actually, one of the neurosurgeons who worked in Iraq that time, he was an endovascular trained surgeon. So he was seeing a lot of subarachnoid hemorrhage, traumatic, and he actually looked at closely, and he found that there was a higher incidence of spasm in those patients. I think that's something we typically don't address it, and we don't look at more closely. because one of the things that we don't see isolated subarachnoid hemorrhage, often it's a combination of different things. But there, at least the studies we have, there is some indication that there is higher incidence of spasm in that patient's population.
Thank you. Thank you. It would be an intriguing thing to pursue, I think. And when you mentioned that we're a higher volume center, that's my perception as well. Do you have a sense of the numbers, or maybe the?
I think so the hemorrhagic stroke volume is about 150, if I'm not wrong. Among that's about 80-90% of the patients is subarachnoid hemorrhage patients.
Yeah, it's pretty high volume. So I think our center can actually engage in some research. It seems like one of the attractive areas to ponder is if we could change through anti-inflammatory agents or something that DCI trajectory somehow. Anyone else have questions? Go ahead, Dr. Pillai, you were going to respond.
Oh, no, I was just telling, one of our researcher actually is actively interested in doing, we just need to get him to Dr. John Sang. He's also part of anesthesia faculty, right? So he's one of the areas of interest is early brain injury in subarachnoid hemorrhage.
Is he the one that's in basic science?
Right, yeah.
Yeah, he actually has a NIH grant. I saw that come through the notice for SAH. So it would be an intriguing thing if we could partner with him. If we truly have the volume, maybe we could be a proactive center to have some discovery in this area. Anyone else have a question? Speak up or put it in chat if you like.
Oh, I did not check the chat.
I've been checking the chat for you. I don't see anything. Go ahead.
Yeah.
Not hearing anybody. I know we're towards the end of the hour. For those that are still on, I would just mention this is such an intriguing diagnosis and pathophysiology when you treat these people. I think my current record for salt wasting is 50 liters in a day, and trying to keep that person normal bulimic is quite a challenge. And I never thought I'd see Takatsubos more than once or twice in my career. I see it every other month on service in this patient population. So it's quite something.
Yeah, the other things, again, I was interested, I don't know if it is, I think we see a higher number of patients with drug abuse. And that's the population. We see younger patients, and they also have multiple lesions. And this is again, something we may have to be, we have to look at those patients more closely. I think they come with a poor grade. They tend to be smaller lesions. Yeah. And they're typically younger patients too. So I saw Carrie Kubo from Stroke. Is she there? I think she can answer that question about numbers of the number of patients from hemorrhagic stroke, if she's there.
What was the question, Dr. Pillai?
Just our total number of subarachs.
Oh, I can get that for you. You'd think I'd remember it off the top of my head, but I don't.
That's fine. So go ahead.
Yeah, the one thing we found that compared to the national average, our numbers are definitely higher.
Yes. Well, again, I want to thank you so much. Great topic. To remind everyone, there's a survey you can fill out. This is a CME lecture. We record them. You can follow up,